So the next presenter is Arthur Sitt from the United States, who's going to present on what we have learned from trabecular MIGS trials.
Thank you very much. It's a pleasure to be here. So my talk will be a little bit different. First of all, my disclosures, none of which are relevant. Today, I'm not going to try to give you my opinion on trabecular MIGS procedures. Instead, I'm going to talk about an ophthalmic technology assessment from the American Academy of Ophthalmology, which looked at trabecular procedures combined with cataract surgery for open-angle glaucoma. And this is work from a panel, actually led by Grace Richter, and I was privileged to be part of that panel. So what are the AAO ophthalmic technology assessments? So these are documents that the American Academy of Ophthalmology creates to evaluate new and existing procedures, drugs, diagnostic and screening tests. And the goal of an OTA is to review their available research for clinical efficacy, effectiveness, and safety. For MIGS, the goal of this particular OTA was to review the current published literature on trabecular procedures combined with cataract surgery in adult patients with open-angle glaucoma, and specifically was to evaluate FDA-approved trabecular procedures with and without stent implants, including iStent, Hydrus, excisional goniotomies, including trabectome, as well as the Cahook dual blade, and trabeculotomy with gonioscopy-assisted transluminal trabeculotomy, or GAT, and OMNI-assisted trabeculotomy and canaloplasty. So the specific assessment questions were, first, do trabecular procedures in open-angle glaucoma patients undergoing cataract surgery provide sustained IOP reduction or reduced medication burden beyond what would be expected from cataract surgery alone? 2, do trabecular procedures compare with one another in terms of efficacy and safety, and what are the advantages or disadvantages of each procedure? And then 3, are certain patients who may benefit from one procedure over another? So the evidence started with comprehensive reviews and PubMed studies, or limited to English studies, or studies that were published in English, conducted up until February 2021, and then a second review was performed in April of 2023 with, as you can see, pretty comprehensive search terms. 279 abstracts were pulled out based on those searches, and then 20 articles were selected that met the inclusion criteria and were reviewed in full text. And those inclusion criteria were studies where the primary objective was to evaluate outcomes or complications from trabecular procedures combined with cataract surgery in adult patients with OAG. It had to be original research and had to have at least 6 months of follow-up. And then the evidence in each of these studies was assessed based on the Oxford Center for Evidence-Based Medicine scale. Level 1, 2, and 3 were level 1 were well-designed and well-conducted randomized clinical trials, and then level 2 were well-designed case controls and cohort studies and poorly randomized studies, and then level 3 were case series, case control studies, and historically controlled studies. So of all of the articles that were pulled out and reviewed, 20 met the inclusion criteria, and of those 20, 10 had level 1 evidence. And only studies with level 1 evidence were included. And the effect of that was any studies that looked at trabectome or ab-internal canaloplasty or GAT ended up being eliminated. And then the goal was to focus on mean IOP reduction and mean medication reduction when that was relevant. A couple of notes about the published studies. So all of them were industry-sponsored, and then all the patients had hypertensive glaucoma, mild to moderate stage. They're on medications, and they're undergoing concurrent cataract surgery. Some studies included only POAG, while others included secondary glaucomas, including exfoliation and pigmentary. So what did these studies find? So first of all, in terms of iStent, there were 2 large randomized clinical trials evaluating iStent efficacy. The first, for the Gen 1 iStent, did not wash out their patients prior to assessment of ILP efficacy, and that complicated a lot of their results. So at year 1, there was no difference in ILP reduction although there was a favorable effect in terms of medication reduction. By year 2, however, they do start to separate a little bit. So you still have a reduction in IOP, relatively small, 1.5 millimeters of mercury, whereas the effect in cataract surgery alone essentially has disappeared. And again, you maintain a small improvement in terms of medication reduction. For the second generation iStent, the iStent inject, these were washed out patients, and at 2 years there was a statistically significant benefit to having iStent plus cataract surgery versus cataract surgery alone in terms of IOP reduction. So 7 millimeters reduction versus 5.4 millimeters reduction. For Hydrus, there are also 2 main randomized clinical trials. The Hydrus 2 washed out their patients, and they found at year 1 IOP reduction was again slightly better with the Hydrus than with cataract extraction, a 36.9% reduction versus a 34.6% reduction. And then again, that also spread out a little bit as you get further away, so a larger difference at year 2. The Horizon trial was a similarly designed study at year 1, again showing a positive effect of Hydrus compared to cataract surgery alone, persisting to year 2. And then by year 5, much of the effect has been lost, although there still is a benefit in terms of reduction of medication reduction and possibly slower visual field progression. Now, for excisional goniotomy, there were no pure RCTs looking at KDB alone, but there was a randomized controlled study comparing KDB and iStent, and what it found is that without washout, both KDB and iStent resulted in about an 11 to 15% reduction in IOP compared to cataract surgery alone, but there's no difference between the 2 devices. And then the medication reduction were also the same between the 2 devices. So how about comparing iStent to Hydrus? So there were no direct comparisons in terms of randomized clinical trials, but the 3 independent studies that did have similar designs, which allowed us to compare their efficacy. So the iStent inject trial, the Hydrus 2, and the Horizon trial had similar study designs. And all 3 of them reported IOP reductions, which were actually pretty similar. So 28%, 28%, and 21%. So between 5.4 and 7.6 millimeters of mercury reduction. So the additional reduction over cataract surgery alone was very similar between all of these trials, with a little bit of a benefit towards the Hydrus devices over the iStent inject. And then all 3 trials also reported similar reductions in terms of medication reduction over cataract surgery alone, with a 75% reduction for iStent inject and an 80 and 77% for the Hydrus. So in terms of efficacy, to summarize, there's no clear benefit of adding one procedure over another. In terms of additional effect beyond cataract surgery, an additional 4 to 9% IOP reduction can be expected by one of these devices over cataract surgery. But remember, cataract surgery alone reduces IOP by about 21 to 28%. And so this additional effect really means that you can expect to eliminate, you can reduce IOP by 5.4 to 7.6 millimeters of mercury, or you can eliminate about 1 eye drop. So how about safety? So none of the studies report safety uniformly. Uveitis seemed to be a little bit more common with the Hydrus than the iStent inject, but a pretty low rate. Hyphema, again, a little bit higher with Hydrus than the control group, and with KDB compared to iStent, but again, pretty low rate of hyphema. And then corneal edema did have a slightly higher rate of corneal edema versus the control group, but the statistical significance was not reported in their studies. And then in terms of secondary surgery, and low rates in both the treatment and control groups for both the iStent as well as the Hydrus. And there are no reports of secondary IOP lowering procedures in iStent versus KDB. In terms of endothelial cell loss, there was no statistically significant difference for either iStent or Hydrus. And then important to remember, there are some limitations of the data, even when we just look at the high-quality randomized controlled trials. And first of all, None of these studies looked at normal tension glaucoma. All of them looked at hypertensive patients, and so randomized controlled trials for NTG patients are clearly needed. And there is the risk of industry bias. All of these trials were industry-sponsored, usually registration trials. Nearly all of them had first or corresponding authors who had financial interests in the companies, and so there definitely is a need for future studies, randomized controlled trials that are not industry funded to try to balance the literature. So in conclusion, trabecular trial procedures do seem to offer mild IOP reduction beyond cataract surgery alone in hypertensive open-angle glaucoma patients of moderate to mild stage. The IOP reduction is about 2 millimeters of mercury beyond cataract surgery alone, and that results in about a 0.4 reduction in number of medications at 2 years. The trabecular procedures alone can reduce the need for cataract surgery by about 1.8 to 2.5%, reduce the risk of secondary glaucoma surgeries beyond cataract surgery alone by about 1.8 to 2.5%. And then studies with visual fields as primary outcome are definitely needed. So based on available data, though, there is no clear benefit of one procedure over another. So thank you very much, and hope to see everyone in Hawaii in a few months.
Thank you. Questions for Arthur? Tony?
Thank you very much for a really very nice presentation. My question is actually not only to you, but to the panel as well. In this study, I think all these studies, it's defined that the success rate of 20% of IOP lowering. If we think now about medications, if you want to get a new medication on the market, the benchmark is the prostaglandin, or maybe the beta-blockers, so it would be at least 25% of IOP lowering. Don't we have a too low a level of IOP lowering effect to define that it's a success? Because it's an invasive procedure, so you should expect actually even more efficacy to define it that it's a successful intervention.
I think that's a great point. You know, when do we actually use these devices, and what is the clinical benefit? And I think so for this OTA, that's why it focused on the use of the device concurrent with planned cataract surgery, and as you saw, there was a modest benefit. I think it would be a much more difficult argument if you were using these devices as standalone procedures.
And I think also the definition of 20% comes because they're not comparing to drops, they're comparing to these clinical trials like TVT, where they looked at 20% reduction in IOP for the in terms of defining success, basically.
Any other questions?